Good evening, good afternoon, and good morning. This is the 1584th day of continuous webinar conducted by International Forum for Promoting Homeopathy. Today, our guest is Dr. Mohammed IRFAN from Hyderabad. Let us begin the session with 1 minute silent prayer. Thank you all. The International Forum for Promoting Homeopathy was formed at the time of COVID by a group of homeopathic lovers and homeopathic doctors and students. And this forum is going in a regular webinar session since then, and we have 3 sessions thereafter. That is 7:30 to 8:30, the Hindi session that is already over today, and from 8:30 to 9:30, the international session in English, and 9:30 to 10:30 local language session in Malayalam. All these sessions are going in a good way, and we are uploading the videos of the same on the very next day itself, so that those who miss the session can watch it again and you can share it with your friends without paying any money. So that's the purpose of this forum, is to promote homeopathy and to take homeopathy to each and every home around the world. And we are achieving the target slowly, day by day. And we have more than 6,000 subscribers in our YouTube channel, IFPH Homeopathy. You can subscribe the same and watch the videos again and again and share with your friends without paying any penny. So let me come to today's session. And we have a guest in Professor Dr. Mohammed IRFAN. Sir has completed MD and has some certificates in maternal infants, young children nutrition, and then a foundation certificate in palliative care from MPTL and MPCH, and is a good clinical practice certificate from NIDA, clinical trial method, and is working as the professor and HOD Department of Pediatrics in JIMS Homeopathic Medical College Hospital and Hyderabad. He has more than 2 decades of experiences with him, and has presented various sessions at the national as well as international forum. He has won many awards, and Doctor is talking today a beautiful subject, that is clinical experiences in pediatrics. That means Doctor has a lot of clinical experience with pediatric cases. Let us see what Dr. Professor has to say here. Welcome, Doctor.
Dr. Dhanesh, I have to say something about Dr. IRFAN.
Yes, sir.
I got the reference of Dr. IRFAN from Dr. Naveen Pavaskar and Dr. Manoj Patel from Dhawle. So 2 persons different separately they recommended that you must call Dr. Mohammed IRFAN for your session. So over to you. Thank you, Dr. IRFAN. Please start.
Very good evening, sir. Thank you so much, sir, for providing this opportunity to share my experiences with you. And this is a wonderful platform. I've joined around 15 minutes back, and I've heard you talking about all your experiences and how we have to be students throughout our life. Thank you, sir. With this, I start my session.
Yes. It's fine, sir.
Yeah. Can you see my screen, sir?
Yes, we can see the scene. Everything fine, you can go ahead.
Okay. So this is just an outline of what experiences I've gained over the last so many years of working in pediatrics. We also deal with a lot of adult cases as well in gyms. And I'm here in gym since last more than 13 years now. And over a period of time, I've gained a lot of knowledge and experience of dealing with different types of cases. But today I'll be dealing with only cases in pediatrics. So the objectives of this session will be to understand the importance of correlation of a good history taking, impeccable examination or observations, and relevant investigations in whatever cases we deal with. And using all these in understanding aphorism 3 of Organon of Medicine. Okay, and understanding the importance of bedside training in IPD setting in an homeopathic institute. So these cases which I'll be sharing with you will also highlight the importance of all these knowledges which we are told by Dr. Hahnemann in his aphorism number 3. So history taking in pediatrics is generally involves several unique considerations compared to adult history taking, as children may be unable to communicate effectively. And the history often relies on the parents or caregivers for information. But when we say this, the parents or caregivers, we should not always rely on their data as well. If the child is old enough to talk or to express himself, we usually try to share a rapport with him or build a rapport with him and try to get data as well. Because children, as you must all be knowing, that they are very pure in their expressions. They don't have any filters like adults, right? So as children, most of them, they would just walk into your OPD, they try to share a anecdote or share something which they have done. And over a period of time, when you try to build this rapport, they just walk in without any hesitation, even when there are patients in your OPDs. And they try to pick up your stethoscopes or they try to run around in the OPD. And this is the reason that we should not try to put any restrictions on the children when they come to meet you. Because when the parents are coming to you, they are coming with complaints. And if we also try to be like parents, we will not be comfortable talking to us, right? So if to build a good rapport with the children, we have to come to their level and try to build a rapport by understanding their lifestyle, by talking about their daily routine. So history taking in pediatrics will not have a fixed case taking format or pattern. You just have to start by talking to them, by understanding what has happened, how they are doing there in the schools, and how is their communication at family level or in the society. So that is one thing which I would like to focus on, that pediatric history taking, like we do in exams, should not be copied word to word in the OPDs or in the IPDs. So like I told, you have to come to a diagnosis. History taking is very important, and the observations and examinations have to be very perfect. And that will help you to understand where this history of the patient is going towards what direction. And to confirm that, you have to.
Sir, the screen is not moving. The first screen itself, you can put it in slides. So
This is the second screen, sir.
the first slide, the first slide, clinical experiences in pediatrics is there still. So you may put it in a slide. So then automatically.
It is in slideshow only, sir.
Then you may make it big. It may be stuck there. So we can do one thing. You may stop
Stop sharing.
screen sharing and restart sharing. Then it will be okay. Okay, sir. Okay.
Now, sir.
Now it is objective. The objectives.
Yeah.
Okay.
Is it okay, sir, now?
Yes, it's fine. You can go ahead. History taking in pediatrics.
Okay. So this is what I was talking about, that when you have to communicate with the children, you have to come to their level and start talking to them and try to understand why they are suffering. Right? It is just not the routine case taking which we do with adults or the textbook pattern of case taking. So coming to the diagnosis, how to arrive at a diagnosis is a perfect history taking, right from the talking to the child and then getting the additional data from the parents or the caregivers, and then combining with observations and examinations, and then going ahead with the required investigations, which will help to confirm the diagnosis. Okay, so this triangle has to be very perfect. All this has to come over a period of time by doing it again and again in each and every case, and each and every case will teach you something. So that is what I want to focus on this platform. So coming to the first case, I'll be starting with the first case, which will be a case of a 3-year-old boy who presented with eruptions all over the body since 1 week. Okay, so when we talk about a 3-year-old boy, we have to rely on the data from the parents. Okay, and the rest of the thing is only observations and examinations. So this 3-year-old boy, we usually have 24 villages which we are covering as a outreach program. So from there, one of the doctor got this patient to the hospital. When I say eruptions, we usually come out with a lot of eruptive fevers cases and a lot of cases which are acute cases. Some of them might be chronic cases. So this, let us see what is the history of this child. He had started with fever a week back after the eruption started, and he was taken to a local doctor who prescribed all these medicines which I have listed out: permethrin lotion, ciprofloxacin suspension, and antipyretic. And after the medication, the fever had come down, but the other symptoms were persisting. That is, the skin complaints were persisting. And when he was got to the hospital, there was no fever. Now, people might ask why a small child who has only skin eruptions needs to be admitted. So here, the observations need to be taken care of. And for that, we need to admit. And since we are in a teaching hospital, we try to admit patients so that the students learn from bedside training. Okay, so that is one reason that we focus more on admitting patients so that the observations are perfect. And after giving the medicines, whatever comes as a simillimum, we have to see that the follow-ups are perfect, and you can judge whether the medicine is acting or not acting. So at the time of admission, the patient did not have any complaints of fever. And here's the description of the lesions: diffuse maculopapular eruptions on the back, in the chest and extremities, the papulovesicular eruptions on the right ear pinna, face, and upper extremities, and serous and offensive discharge from eruptions of the face and extremities, and serous discharge and bleeding from eruptions on the ear pinna. Okay, so these are the different types of eruptions in the same child, and which had different types of expressions as well. And coming to the location, the eruption started on the webs of the finger of the right hand and then spread to the left hand and then to the rest of the body. Started initially as scaly eruptions on the webs of the fingers, and later maculopapular and vesicular eruptions developed all over the body. There was severe itching with burning pain. Itching, again, it has to be an observation that the mother observed that the child is going on scratching. Okay, the child might sometimes tell, a 3-year-old might sometimes tell that it is scratching or itching. And with that, there is burning pain. And the mother has observed that the itching is mostly aggravated at night. And with this, there was concomitant, which was the swelling of the face. Okay, and there was no other cause for this eruptions to come, no history of any food or medicine taken before the complaint started. Coming to the past history, there were recurrent episodes of URPA, which has been there on and off. At this age, it is quite expected that the child of this age might come down with URPA because of the lifestyle, which usually the children go to the school or they take cold drinks or ice creams, which is quite common these days. And then they come down with eruptions causing absenteeism from the school. Coming to the family history, the father had eczema, mother had psoriatic eruption similar to that of the child after coming in contact with the patient, but the similar skin complaints were there in an elder brother. And since that was there since last 1 month. Let us look at what are the changes in the, when we see acute cases, we also have to see what are the changes in the generals of the child, where the patient complains and at the same time there are changes in the generals. For example, here you see that there is appetite decrease, which is quite common when the child has a fever, but there was perspiration which was increased. And coming to the mental generals, the child was very restless. He was admitted in the IPD and he was going on walking throughout the ward, and he had 2 elder brothers with whom he used to quarrel. And whenever he is asking something and he doesn't get it, he beats his elder children. Very particular about his dressing, wants his mother to dress the way he likes, and he's quite fearless. Tries to pull the dogs by tail or throw stones at the dogs. Does not obey his teachers, parents' words, and does things which he wishes to do. And whenever something is taken away from him, And if he is not allowed to get what he wants, then he is getting angry and beats others. Now, the question is, when there is an acute illness, why do we need to take so much of details? So why we have to take this is because we can judge by this whether there is any altered state of mind during the acute illness. That is one reason. The other reason is to try to see from that situation preceding the onset of the disease if there is any change in the surroundings. Is there any change in the life of the child, of the patient? So that is the reason that we take the details of the life space as well. And seeing that this complaint which was there, that there was puffiness of the face, mostly on the right side of the face, and eruptions which were oozing serous discharge and bleeding at times with puff. The vitals were okay. And this is the skin eruptions which were done on examination, which has been described in the history as well. So I'm not going into details of the examination again. And this is the picture of the child. You see the first, this is the day of admission. The child had eruptions all over the, most of the face is covered with eruptions. And you see this eruptions which are already oozing few of the serous discharge. And sometimes there is, this is the crust which is formed after the discharge from the ear has come out. And you see the swelling on the right side of the face. And there's one eruption which, because of the scratching, he has had to all the scabs which have come out, and there's few eruptions on the back. And the rest of the eruptions are on the feet, and you see mild swelling of the left foot as well, with scabs which are coming out. And because of his intense itching, he cannot stop his scratching, and he has been peeling off the skin from the eruptions. So coming to the diagnosis, I think most of you have already come to the diagnosis that it is not very uncommon these days, especially in the children, school-going children. So this is a type of scabies, okay, which is also called as crusted or Norwegian. Previously, it was called as Norwegian scabies. Now it is called as crusted scabies, and which had superseded secondary infection. Now, when we see this case, we have to rely mostly on the examination findings, and that is the reason that we have based our prescription on the examination. So when we see these eruptions, what we see is the kind of eruptions which are mostly pleomorphic eruptions, taking a stage from right from papule to papule. This pustule, macule, everything is you can see in this child. But what strikes is the eruptions which are covered with scabs. Okay, and these are the eruptions which are covered with scabs, and once the scabs are removed because of the scratching, the child, it oozes out a lot of pus or a serous discharge, depending on the stage of the infection. So that is the reason that we base this prescription on observation. And the observation which, when we went back to the materia medica, and we also had to rely on these reasons for the selection of the remedy, that is, eruptions ulcerate and forms thick scabs under which purulent matter exudes. Inintolerable itching, itching with burning, and aggravation night. So this is the only observation which we have made in this child, based on which we have prescribed a remedy which is called as mesarium. Okay, so mesarium 31 dose was given. Since the child was with us, we did not repeat it immediately. We waited for some time to see how the medicine acts. And that is the reason that we always ask the students to keep observing the child, taking the follow-ups quite often, and see what are the changes in the child. So after this, and we also have to form a follow-up criteria, because we cannot just keep on asking, how are you, how are you? We have to see what are the improvement in the generalities, and relieving the complaints, which is right now for the child is, which is troublesome, is the itching. And also taking care of the puffiness of the face and controlling the spread of the secondary infection. Because Norwegian or crusted scabies has a high chance of spreading to other people. And 2 people are already suffering in the family. So this first prescription was on 2nd of December. And the next day we see that the eruptions are still the same, itching is same, burning pain is same, offensive discharge is same. Now we started repeating, but the itching was slightly better. Okay, so we started repeating the dosage, so we made it twice a day. And on the fourth, we see that there is no fever, but the discharge on the eruptions on the right ear, pinna, which is thick yellow discharge. Okay, right ear pinna, which had crust, now started oozing a thick yellow discharge, which also was coming from inside the ear. Okay, so since you see that the past history of the child is that the child has been suffering with recurrent URPA, so there might be chances that the child might have developed a suppurative otitis media as well, which we are not sure, but because the eruptions were covered inside the ear pinna as well. And from there, the eruptions were oozing out pus. And the appetite had improved, which was one good sign. And over a period of time, I've realized that kali sulf 3x in the biochemic form usually helps in this kind of thick yellow discharge from the ear. So along with the mesarium, I added kali sulf 3x. And fifth, we see that the eruptions, the discharge from the eruptions was reduced and itching had reduced by almost 40% according to the mother. And there were no new eruptions which had come. And we continued this and we changed because the itching was there. It was still not completely better. We changed the potency to 200 and we made it and added kali sulf 3x and continued with that. And sixth, you see that the discharge from the eruptions was very scanty and itching was reduced and eruptions also had decreased by 40%. And main thing, the puffiness of the face had reduced by 60%. So we continued for one more day, the same potency, kali sulf 3x and mesarium 200 for the next one day. And next day, the parents insisted because they had to take care of the other two kids at home. They insisted for discharge. And since this child would be seen in the next follow-up in the village itself where we visit, so we discharged the patient on the right day, next day, because that is on 7th, where there was no discharge, puffiness of the face was completely reduced. And itching was still present because that will be remaining because there are a lot of scars which are left over. And eruptions are still present. So patient was discharged and he was asked to come after a week. But after a week, he didn't come. And when he came back to the village camp or the peripheral OPD, there was no discharge, there was no puffiness of the face, and no complaints of itching as well. So the child had completely recovered. That is the reason the parents, because they are daily wage workers, they did not come to report to the hospital or the peripheral OPD. The scar marks were still present on the right ear field. So this is how the child looked before the treatment. During the treatment, that is the fourth day of the admission at home in the office or in the hospital. The puffiness of the right side of the face has gone, right? So this is the before treatment, and this is what you see during the treatment on the 6th, just a day before the discharge. And the third one you see is after 3 weeks. So the few scars were still remaining, but the rest of the scars all over the body had gone. So this case has taught us that eruptions which are of different types. Okay, so you have to make a close observation of what type of eruptions are there and what type of discharges are there. And based on that, sometimes over a period of time, because mesarium came to my mind because we have also treated a lot of diabetic foot cases where the scabs almost look like healed. The diabetic ulcers almost look like healed ulcers. But when we are dressing, once the scab is taken off or comes out during the dressing, we see a lot of pus underlying that scab. So that is one reason that we have seen good results with mesarium helping these diabetic foot ulcers. Also, and that is one reason that we selected mesarium in this kid also. So coming to the second case. So this is an interesting case where we have learned a lot about the importance of understanding the case in detail. Okay. Let us see how this case unfolds. So this is a 14-year-old boy studying in 9th class and who had come to the hospital with his parents. Now, when they came to the screening OPD for the first time when they came to the hospital, they had come with a report. Okay, the report suggested that the child had been asked to get operated. So this is the background that the patient had come asking whether the operation can be avoided. So the pain in the right iliac fossa since 2 days. So this is on 4th of July. Okay, so this is the history that the patient had complaint of right iliac region pain since last 2 days, and which was ameliorated by bending backwards and sitting, aggravated by walking, raising from the sitting position, and pain remains for 5 to 10 minutes. It comes suddenly and it stays for around 5 to 10 minutes, and suddenly it vanishes away. And he passes stool 3 to 4 times a day since last 2 days, in soft yellow stools immediately after eating. So this was one thing which the mother was mentioning, that as soon as eating, is going to the washroom to pass stools. And fever since 2 days, aggravated in the mornings, and bitter taste since morning, perspiration on feet since last 2 days. And along with the stools, there was no bleeding per rectum or no vomitings. And as the history was told by the mother said that he had eaten egg rice for 4 days continuously during the last 1 week. And since that is the reason that the mother had beaten him for not eating at home and going out and eating. And then he got fever, and then he went to the hospital for checkup, and everything was normal, and the fever subsided within 1 day with the antipyretic, supposedly antipyretic remedy, medicine which was given to him by the local doctor. And per abdomen, there was soft per abdomen with the tenderness at the McBurney's point. I have but no doubt that most of you have guessed what is the diagnosis. So it is a case of acute appendicitis. Okay, so you see the report which says that inflamed appendix with a AP diameter of 7 mm with increased vascularity and probe tenderness in the right iliac fossa. So this is the report which the child had come with, asking whether the surgery can be avoided. So here is a case of a surgical illness which most of you must have treated and seen good results with homeopathy, and where surgery has been avoided. Now, what is the acute totality which we see? A pain which is bending, better by bending backwards, better by sitting. And inflammation is one thing which we have to focus on when we are taking. But main thing which comes to the mind is the pain comes and goes suddenly. And in the IPD also, the patient was sitting very comfortably when we go, and suddenly the pain comes and he becomes a little in distress, and then he bends backwards and or sits on the bed, and then the pain goes away. And so this is the only 3 things which I have selected for the repertorial totality: pain bending backwards, inflammation, and pain better by sitting, amelioration. But what made us to differentiate between belladonna and naxomica is one rubric in Pathak's repertory. It says that pain comes suddenly and goes suddenly. So that is, belladonna is the very important remedy in acute inflammations where the pain comes suddenly and goes suddenly. So that is the reason why we chose belladonna. And belladonna was prescribed even before the repertorization based on my clinical experience of looking at the person, his symptoms, and this main characteristic that the pain is coming suddenly and going suddenly. And rest after that, the PG scholar took up the case in detail, and then we came up with the rest of the history. So pain was better after medication. For 1 day, we gave this medicine initially every second hourly, and next day we made it 4 hours. And there were no spikes of fever. There was no pain in the morning and afternoon, as it was told in the initial last 2 days that the pain was mostly in the morning and afternoon. And he had passed normal stools, and the appetite also had improved. And coming to the past history, he had typhoid, chickenpox, and nothing much was very significant. And looking at the social history, like I told you, history taking in acute cases, once the pain is subsided, okay, now you get enough time to talk to the patient. Since he is admitted, we have enough time to talk to him at length. And when I say at length, it should not be one sitting also. If the patient is in distress, do not continuously keep on talking to the patient, give him some rest, come back again and talk to the patient again. So that is the relevance when the patient is in front of you, that you get to see the patient, get to observe his expressions, his body language, and then decide what best can be done for this patient based on his symptoms and observation and your observations. So here we see that the child is the elder one of three kids, okay? And he has a good rapport. Sometimes they fight with each other. And he was thirstless during this episode, and he has desires for pickles during this episode. And he had perspiration, and he was thermally ambithermal. Now coming to the life space, like I told you, once the patient has settled, we also have to see where this pain has started from. What is the reason that this pain has started? Why this patient is suffering? Why this child is suffering? So child, taking the life space in detail, the child was very active since childhood, mingles with everyone. He listens to his parents, but since he's the elder one, he gets most of the ranking. And whenever he is troubling or whenever his younger siblings are troubling and he tries to fight with them, he is the main target for his parents' anger. So what he does, he cries, doesn't eat food, and sits alone. So there's a lot of sulking nature in this child. And along with that, he has fear of darkness, fear of dogs, and he's scared of his father because he keeps on beating him most often. And he doesn't spend most of the time at home. Whenever he fights with his siblings, they scold him and tells him to get out of the house, which he doesn't like. So there's a constant reprimand at the house, okay? And there's a constant comparison with the younger children, where the child is getting most of the beating because he is troubling the younger siblings. And this emotion of anger, he keeps on sulking and he keeps on keeping within himself. Okay, and he goes into the room and sits silent. That is his usual pattern, that whenever he gets angry, he goes and sits alone, doesn't want to talk to anyone, and he doesn't share with anyone because he thinks that there's nobody to listen to him, and everything he keeps within himself. Now the turning point of the case is a week ago, his close friend, he usually shares everything with him. Now you see the child who has been at home not getting enough attention. Okay, then he has a school friend which he is very close to and doesn't share. He didn't share about a fight with another person, and he got angry on him. This patient got angry on his friend that he didn't share something which was related to one of his friends. He didn't talk to him for after that. And after that, he didn't go to school for 3-4 days because he didn't want to face that child, one reason. And the second reason was he didn't finish his homework. And because of which he again got beatings from the mother, and he was forced to go to school, but which he didn't want to. And since last 2 days, he's been suffering with his child. So now you see the psychodynamics of a child who is already sulking, who is angry, who is not getting enough attention at home. Now he goes to school where he has a school friend, but he also has sometimes he has that feeling that he has not shared something. So now you see a simple word of anger. Usually, most of us try to overframe this anger into indignation, mortification, ailment from admonition. All these thoughts come to our mind. But let us keep it very simple, okay, and focus only on the anger part. So, what is the main thing which has happened is anger, which has led to his immunity, which is depleting, and then added on, he has started developing inflammation in the body. Okay, and you see only these things which can be focused on in this case. That is, he has suppressed his emotions, which he cannot express at home, and he doesn't want to face that friend and talk to him because he has so much of anger that he doesn't want to express to him also. And then you see that this appendicitis has developed. So based on this, all the examination findings which have come up, you see this next day again, because the pain had subsided with belladonna, we sent him again to see whether there are changes at the structural level as well. So second was the first scan. 4 days later, we sent him for a scan again. One thing I want to share is that when you're sending for ultrasound, see that you send it to the same center where the previous scan is done, if possible. If it is not possible, fine. But if you try to send it to the same center, the radiologist or the sonologist who is there will have an idea and give a comparative report. which will help you in understanding whether the medicine is acting or not acting. So here we sent the patient to the same center where we had got the first scan done. Although we had a facility at our own hospital, we sent him to the same center to see what is the changes. Now the size AP diameter has come down from 7 to 5.4, and the probe tenderness was not there, and there was no detectable vascularity which was seen in the first scan. So radiologist himself mentioned that compared to the second July scan, the inflammation has subsided, and he marked it as a subacute appendicitis. Now you see this phase totality. What we have taken as the first prescription for belladonna was an acute totality. Now you see you have got the causation, right? Once you get the causation, you try to trace the evolution of the disease right from what went wrong before the inflammation started. And then you come up with this totality: a suppressed emotions, ill effects after anger, and colic after anger. And he has this aversion at a general level to milk and yogurt. And then you see this repertorial sheet, which shows Staphysatia, Ignatia, Naxomica, Magmore, Natrimor, Natrimsulf as the first few remedies which have come up. And when you go back to Materia Medica, because once we repertorize, repertorization is only a link or the bridge between your understanding of the disease and your understanding of the medicine. So once you get the glimpse of what are the remedies which can come up, you again have to go back to the final court of justice, that is the Materia Medica source books, and you see in Boric that you have this phrase, colic after anger, and Staphysatia is the remedy which comes up. Okay, along with Natrimor was there, Naxomica was there, but we selected Staphysatia based on this understanding that the colic has started and after an episode of anger. Okay, so that is the reason that we gave Staphysatia 200 dose and we kept him on placebo, because belladonna had already taken care of the acute episode. Now we have to give him something which can treat the rest of the causative factor and then heal the patient completely. So 1 week later, he came back and there was no pain or fever, and generals had improved, bowel movements had improved. There was no other signs or symptoms for which any medicine was needed. But for our understanding, we advised him to get an ultrasound done whenever he comes back next time. But he didn't follow up again because there was some death in the house, so they didn't follow up. So we again called the patient to understand what has happened after medicine has gone. So we asked them to get a scan done, and this is on 30th of July. Because of our insistence, they went back to the same center, and here you see that the appendix is a normal size and it's an AP diameter of 4 mm, and there was residual reactive lymphadenopathy. That is the only thing which was left over, and at this age I think it is quite common to have lymphadenopathy in the abdomen. Okay. So cessant causa and cessat effectus. What does this mean is you treat the cause and the effects are gone. So that is one important learning which we get to learn from homeopathic scholars. Especially Kent has mentioned this in his lectures as well on philosophy, that you treat the cause. And for treating the cause, you have to get to the root of the cause. Once you get to understand what is the cause for a physical ailment. So here we find that there's a mental cause for a physical ailment. So basically it's a psychosomatic illness. But usually we don't see that appendicitis can have some such cause. But because of the diligent case taking by the PG scholar who has gone into the depth of understanding what has gone back in the background, we could treat the cause and the effect also was gone. 3 months later, again, we called him for the follow because the mother had complained that whenever he's eating, he has been passing stools in the initial follow-ups. We asked him to come back, and 3 months down the line, he came back again. There was no other episode of pain or fever after the last medication. Everything was running smoothly, so we didn't give any medicine except for placebo and asked him to report whenever there is any other situation. So pediatrics is the art of observing a child's silence as much as listening to the complaints. So in pediatrics, case taking should not be only to observe. what led to us to take the case in detail was that even after the belladonna episode, which had treated the pain or the inflammation part of it, he was not looking okay. Okay, he was sitting quietly in the. There was something which was lurking, and the facial expressions which were forcing us to ask him what is wrong. And that is the reason that we took the case in detail, and that is what we came out with a beautiful explanation of why the child is suffering. Right. So that is one thing which we learn from this case. And in pediatric care, observation is not just about seeing symptoms. Okay? When we talk about observation, it's not about seeing symptoms or what we observe with our eyes. It is also about using all our senses. Okay? Listening to the child, observing their behavior in front of you, away from you, because the other uh, nursing staff which might report you about the observations that they have, or understanding the subtle clues they give us. This approach is at the heart of homeopathic practice, where we treat the child as a whole, not just the illness. Coming to the third case, which is again a very important case. This child, I would take the opportunity of presenting this as a pediatric case because this patient has been there with us for a long time, since the child was a teenager. So, but when this child came with an acute episode, she came with a fever. Okay, so that is the reason that I've taken up this case, because here also we have an important learning to discuss. So she had cold and cough since 5 days, fever with chills since 5 days, nausea and vomiting since 5 days, and rashes all over the body since last 2 days. When you go into the history, she had apparently healthy, and she had gone to some hostel to drop her younger brother, who had joined that hostel for further education. And while coming back, she had drenched in fever. Okay, and then subsequently, all the symptoms started with the fever, with drowsiness, nausea, vomiting, difficulty in passing stools, and then she had this fever, okay, which was 99 on day 1 and 101 on day 2. And she used allopathic medicine, but she was not completely better. When she came, she had already taken a dolo tablet, and hence the temperature recorded was normal. But giving a background of how this case came, she came to the OPD and she was a little dull as compared to what she usually comes to the OPD with other complaints of URTIs. And she was the main symptom. Why I'm telling you this is when your patient comes to you, you take the history in detail. The previous cases I have told you that you have to go to the depth of the case to understand why this has started. And here you see a physical ailment that the patient has drenched in grief, and then the subsequent symptoms have started. But when we try to see what is presenting, when I say presenting symptom, you have to focus on right now what is the patient suffering with. And right now, she told me that I'm suffering with severe nausea because of all these allopathic medicines which were given. And based on this and my previous experience, I gave her, asked her to get it investigated because the fever was on and off very high grade fever. And I asked her to get her investigations done. Meanwhile, I gave her 1 dose of Naxomi and asked her to wait in the waiting areas till the reports come back, and asked to come back to the OPD to see me after the Naxomica, what are those changes in the symptoms. So this is how it unfolded, the case unfolded. And then the rest of the case was, once the reports came, then we asked to get admitted, and then the case was taken in detail. So the rest of the slides which we have are taken in the IPD, not in the OPD. So we have the chill stage, heat stage, and sweat stage, which is marked. And this is very important and quite useful in understanding the evolution of the disease and how and what are the things to be taken in the repertoire analysis. And there was cough, which was ameliorated by drinking warm water, and nausea and vomiting, which was there, and vomiting, which was once per day on day 1, which is watery and offensive. And this episodes of vomiting went on increasing, and to the extent that she was afraid of eating and she could not eat or drink due to the vomiting. And the rash, which was pinpointed, rashes all over the body developed on the 4th day. So when we talk about eruptive fevers, we also have to keep in mind when the rashes are approaching. Okay, so that will give us different aspects of what are the eruptive fevers which we are dealing with. and burning sensation and itching all over the rashes, which was ameliorated by scratching. Coming to the past history, she had history of allergic rhinitis when she was at 17 and used allopathic medicine and used nasal spray. And on and off, she was having these acute episodes for which she was under homeopathic treatment after that. And she had sinusitis as well. And mother also has allergic rhinitis and brother has skin allergies. Now you see, because of the fever, there is decreased appetite due to the nausea and vomiting, which is immediately after eating, and she is thirstless. And she is constipated for the last 4 days, which is also one aspect where Naxomica stands out. And on examination, she was well built and nourished. Typical calcarea, I can say, which was fat, fair, flabby child. Of course, now an adult. And she had a dry white coating on the tongue. And the lesions which were non-blanching and rashes were on the hands, legs, chest, and it was warm to touch. And investigations, we sent for routine investigations to check out what is the cause for the fever and to see if we are missing out anything else. And due to the rashes, we also sent for a serological test for dengue fever. And provisional diagnosis was dengue, which was confirmed after the investigations came. And you see, we admitted the patient to see how the fever presents and what are the changes in the fever pattern. And this is the first day of report while the child or the patient was sitting in the OPD and waiting for the reports. And this is the first report. You see a platelet count, which is of only 26,000. And this is one reason that we have to admit and see if the rashes flare up or she goes into other complications of dengue. And now we have to be very cautious when this eruptions are coming and the fever has been on and off flaring up. And the CRP, which is of 11.2, indicating that there are inflammatory changes, infections inside. The dengue NS1 was positive. In totality, if you see, like I told you, the first prescription itself was Naxomica 200, after which she said, when she came back with the report, she said she is feeling a little better with the nausea. And then we asked her to get admitted, and then we took the case in detail. We also came up with these symptoms, which were repertorized, taking into consideration all the acute totalities. And the same medicine luckily was coming up, which was Naxomica. And we continued with Naxomica for next 1 day. These are the other remedies which came up for analysis. And we also tried to repertorize this with the Allen's intermittent fevers book to see if there are any changes or any new symptoms which can be correlated. And to a surprise, the same remedy came up with this repertorization as well. So Naxomica was doubly confirmed. So every 4th early, along with Parampos for the fever, continued. And this is on 3rd of August, 24. And these are the eruptions on the day 1. You see those pinpoint eruptions, or what is usually called as petechiae in dengue. On the next day, we see that there is no fever, pain in abdomen has decreased, body pains has decreased. Nausea and vomiting, which was the most troublesome presenting symptom for the patient, has decreased. And new symptom which came up was slightly blood present in the morning while passing stool. So this has to be taken with a pinch of salt as a caution to see if this child is or if this patient is going into some other complications of dengue. But we were cautiously watching for the other symptoms and we continued with the same remedy. And 5th, we see that the child is active, the patient is active, feeling better in general. All the itching has reduced, mild cough is present, and appetite taste has improved. So most of the generalities have improved. That is one focus when we treat fevers. We have to see that the generalities improve first and then the particulars improve. And the rashes were fading and very few scars were seen. So now the next thought which comes to mind is whether Naxomica has to be continued, whether we have to see whether the patient is still going on suffering with this fever. Okay. So now this, since the mild cough was still present, now the standstill has come where the Naxomica, we have to take two decisions, whether to continue with the next potency of Naxomica, whether we have to give a follow well remedy or a deep acting remedy to take care of the rest of the symptoms. So here aphorism 240 comes to our help, which says, but if the remedy found to be homeopathic specific for a prevalent epidemic of intermittent fever do not effect a perfect cure in someone or other patient, if it be not the influence of a marshy district that prevents the cure, it must always be the soric miasm in the background, in which case antisoric remedies or medicines must be employed until complete relief is obtained. Okay, so this reason we gave 1 dose of sulfur. Okay, and we gave this sulfur on 5th of August, and the patient was insisting that we are, since the I'm okay now, and the parents were insisting because they have to go back to work, they asked for a discharge. So we asked her to get back again with the reports next time when she comes, and this time they were ready to come every day to get it checked and not wanted to stay at the hospital. So next day she got the reports done outside. Okay, so this dengue NS1 shows negative, and the rashes have faded. And this is done 6th. Next day, the patient clicked pictures and he sent it to us that the rashes have faded. And now 7th, when she came, she had come with mild weakness and cough, and cold and cough was still persisting because she already had a history of allergic rhinitis. And overall, she was feeling better. Rashes have completely gone. Thirst is normal, appetite is normal, and tongue is clear and moist. Now, for the cold and cough, she usually responded to natrum sulf-3X, so for which we prescribed the same for 1 more week. And this is the comparative report of all the investigations which we have done. Right from 3rd, if you see this first report which I have already shared with you, the 26,000 came to 38,000 on the next day, and subsequently on the next day itself, it came up to 1 lakh. And this is the day that we had prescribed sulfur, and next day you see that this is the report from outside. It is 1.83 lakhs. And if you see this CRP levels, they have consistently come down, which also indicates that there is improvement at the biochemical levels as well. And when she came back after 1 week, the platelet have gone up to 4.6 lakhs. And the SGOT, SGPT is fine, and the CRP has come down to 2.7. In this case, highlights the importance of understanding how to follow up with the acute remedy and then give a follow well remedy. Okay? We also have to go back to understand the beautiful section which I personally use a lot is the section at the back of the Borix Materia Medica, which gives this table of follow well remedy, inimical remedies, and that we use quite often to understand which is the follow well remedy for giving in any particular case.
Okay, sir, the time.
Yes, sir, done, sir. So all this was possible at this beautiful institution which we have been running for the last 1 year, giving access to quality healthcare and education. And that is the place which I am currently working as. Thank you so much, sir, for your valuable time. If you have any questions, please.
Yes, Dr. Mohammed Irfan, sir, you are a professor and you have done justice in your presentation. All the cases were, even though it is acute one, and then you talk about the importance and relevance of case study, why one need to study the details of the case, why observation is important, what are the causes behind, how you talk about the cause and effect theory and everything. And not only that, you find the right remedy and the right prescription with the right potency also. That is why you were able to cure all these cases. Even the first case that we know that it's a scabies case, people used to think that, oh, it's a scabies case, what we can do. People used to apply some externals and then they may come to us. So people may think that, oh, it is a case of external lab, they are applying, so it's an external application, so we can go ahead with the sulfur like that. But no such prejudice is not required. But you just observe what is there. You just find out that in that case, it is oozing like anything, and there was sticky discharge and all that. you prescribed Meserium in the first case, and that works wonderfully. And as a result, that case was cured. And in the second case of the acute appendicitis, you were able to choose the right thing. You were prescribed for the brain that is very, very intense in that case, and Belladonna has done justice to that case also. And in the third case also, you prescribed in a different way. Anyway, congratulations for the hope we can have some more presentation in the coming days of our session, so that more and more people can understand how a homeopath need to look into different aspects of case taking. Anyway, this is the time for discussion. Only a few minutes remaining. I just invite Dr. Ram Paresh sir to say a few words. Talk in short time, sir.
Thank you, Dr. Dhaneji, and congratulations, Dr. Mohammed Irfan sir.
Thank you, sir.
Very good presentation. Excellent session. Case is the very good case select remedy. The very good select remedy. Cause and effect. So, fever, the very important deal the approaching 240 section, background of SORA. So curative way of treatment, acute case. Very, very thanks.
Thank you, sir. Thank you so much, sir.
Now I invite Dr. Manoj to say a few words in this presentation.
Thank you, Dr. Dhanesh and Dr. Mohammed, for a nice presentation. And we must remember why homeopathy is more applicable or effective in case of these children. Because as mentioned by Dr. Samuel Henneman, there is no much suppression.
Yes.
And again, the artificial diseases due to the application of allopathy medicine is comparatively less. Moreover, there is no pride and prejudice.
Yes.
They are not at all thinking this is a medicine having low cost or sweet medicine will not work. So there is no pride or prejudice in case children. And then the last mention about this observing and listening. That's also very important. These things are also will definitely reflect the original picture. Because we know that then hypochondriacs are there, and the patient is become nature. There has a lot of prejudice and hypochondriacism is there, but in children it is not there. So that it will work more. Moreover, this is, as mentioned by Dr. Samuel Himan, you give a small dose of Nexom, sulfur in between Nexomic, always mentioning. Then some medicines like heparin sulfur and the mercury is also mentioned there. So reading the footnote is an important part in studying homeopathy. Thank you very much.
Thank you so much, sir.
And now I invite Dr. Onkar Anwar to say what of thanks to the session. Dr. Onkar, please say yes.
Hello, sir. Hello, Irfan sir.
Yes.
Thank you for the nice presentation, and I would also like to thank the entire team who presented. And the cases were very short and sweet and to the point. And you also explained the entire thing from the clinical aspect, diagnosis, homeopathic totality, repertorization, and the management and follow-ups also. Thank you for it. So it was a nice learning experience, sir.
Thank you so much, Dr. Onkar.
And thank you for sir to give me the opportunity to say thanks. Thank you. I'm actually surprised. Thank you,
Yes,
sir.
yes, this kind of surprises can everybody can expect in our forum, because we always found that you people from just in dynamic personality like you in this forum. Dr. Onkar, you are from which part of India?
So I am from Maharashtra and I am from Dawri Hospital only. I am from the same college where Irfan sir. Yes, sir.
Yes.
Uh, sir is my super duper senior.
Okay, thank you. Thank you,
Thank you, sir.
thank you,
Sir.
Dr. Onkar.
I am from Dr. M.L. Dawri College, Palghar.
Okay, thank you. Thank you, Dr.
Thank you.
Onkar and Dr. Mohammed Irfan, sir, and those who attend the session in this evening. Definitely, we will arrange some more session from Dr. Mohammed Irfan, sir. And tomorrow we will have a session from Dr. Sumira Abdul Jabbar, and she will be talking about insomnia and homeopathic management. You can join the same by using the same link that we shared to you today. The same thing is used for our presentations every day. So don't miss the race, and you can watch at YouTube the same IFBH. You just type IFBH homeopathy at YouTube. You can find our previous videos also. With that, we come to the end of the day, 1586. It's over to Dr. P. Shaila to moderate the Malayalam session. Thank you all.
Thank you so much, sir. Thank you to Sani sir also for inviting me for this platform. Thank you, sir. Thank you very much.
Thank you very much, sir.
Okay. Thank you, Dr. Thanesh. Thank you, Dr. Mohammed IRFAN. Thank you all doctors.
Thank you, sir.
Namaskaram. IFPH